brief background on our presenter, Dr. Stan Huey. He is the Associate Professor of Psychology at the University of Southern California and a Principal Investigator for an NIMH-funded clinical trial for juvenile gang offenders. Dr. Huey's focus on research centers on evidence-based treatments for ethnic minorities and how ethnicity and culture influence psychotherapy outcomes. His recent work has focused on effective treatments for youth with serious behavioral and emotional problems, culturally responsive treatments for ethnic minorities, and treatment mechanics that account for clinical change. Now I'm going to pass it on to Dr. Stan Huey.
Thank you, Megan. I hope everyone can hear me. It's the first time I've done this, and I'm sure I'll get feedback if it's not working. So my talk today, at least for the next hour and 15 minutes, is going to be based primarily on what I've learned from what I and my colleagues have learned from immersing ourselves in the fairly large literature, as I've learned, on the treatment of ethnic minorities, larger than we thought it was when we started this process. So just to give you some background, back in graduate school at UCLA in the 1990s, Antonio Polo and I were learning about empirically validated treatments, that's what they were called at the time, in our classes, in our clinical work, and under the guidance of our advisor, John Weiss. And empirically validated treatments were treatments that were shown to be effective for mental health problems in randomized controlled trials, basically trials showing the highest level of evidence. Of course, we now refer to these as evidence-based treatments, or EBTs, and that's the term I'm going to use throughout the rest of this talk, EBTs. So we were both interested in the application of EBTs to ethnic minority youth, and with the big question being, did these generic EBTs work equally well with non-white populations and non-white youth in particular? And we were pretty doubtful. Well, because we were ethnic minorities ourselves, and we knew how critical culture was with regard to all aspects of mental health, and also because we were exposed to different theories regarding the role of culture, particularly the cultural responsiveness hypothesis. So I've just changed the slide. And the theory goes, the broad theory goes something like this. There are a number of potential problems with conventional therapies. They were developed for white, Western, English-speaking individuals. For individuals who are trying to get treatment, you're likely to encounter a white therapist. The majority of clinicians in the real world out there are white. And these treatments, and the EBTs in particular, don't consider the language, beliefs, and worldviews of people who are not white, people who are culturally different. So the thinking, according to this theory, is that when culture is ignored, then you have value conflicts between the clinician and the client, which leads to miscommunication. That, in turn, can lead to client discomfort with the therapeutic process, poor engagement in treatment, and if you're not engaged, then obviously there's going to be a high level of dropout, and if someone drops out, they can't be treated, so you have treatment failure. So the thinking then is that when you're working with minorities, treatments have to be culturally responsive, and more specifically, clinicians need to be culturally competent. So being good budding clinical scientists, Antonia and I decided to test the tenets of this broad hypothesis using a statistical tool that we were learning from our advisor called meta-analysis, something I'll tell you a little bit more about shortly. So primarily, we wanted to answer three questions. And we thought we knew the answers to each of these. So first, are EBTs effective with minority youth? Our thinking at the time was, well sometimes, perhaps, but often not, again, because these treatments were not developed for minority youth primarily. Second question that we wanted to answer, do white youth benefit more than minorities from the same treatment? And again, our thinking was, well, yes, because that's primarily who these treatments were developed for. And then finally, do cultural adaptations or ways and methods of tweaking the interventions to make them more appropriate for culturally different individuals, do these things enhance outcomes for ethnic minority youth? And our thinking was yes, and the culturally responsive hypothesis argued the same thing, that adaptations are important. So it took us a long time to answer these questions, and it turns out you can't, say, do a simple psych info search for the relevant studies. So we had to do a hand search through thousands of articles to get a critical mass of studies to answer our questions. So we have some preliminary answers now, and the answers are not quite what we expected. So today I'm going to try to answer 5 primary questions relating to the effective treatment of ethnic minority youth. Are psychotherapies effective with minority youth? What treatments are effective with minority youth? Are treatment outcomes worse for minority youth compared to Euro-American youth? Do cultural adaptations enhance outcomes for minority youth? And then finally, what are the implications for clinical practice? So we should probably talk first about what culturally responsive therapy is. So there is no uniform view. There are lots of perspectives, many theories, frameworks, labels, opinions, and I have just a few of the labels on this slide: culturally competent, culturally adapted, minority specific, and so on. So for the purpose of this talk, I'm going to use the term culturally responsive treatment or culturally responsive therapy, or the acronym CRT, to refer to any effort to make treatments more appropriate for or conducive to ethnic minorities. So first, let's look at what clinician perspectives might be. So there haven't been a lot of surveys that have asked clinicians what they think culturally responsive treatment is, but there have been several, and one of the first was conducted by Luis Zayas, and he surveyed 150 white members of the American Psychological Association and the National Association of Social Workers, and there were 4 broad themes: being aware of existing differences between the clinician and the client, being knowledgeable about the client's culture, distinguishing between culture and psychopathology when assessing the client, and then ultimately taking the client's culture into account when you're doing psychotherapy. And the American Psychological Association has developed some guidelines with the help of a number of experts in the field. There are 3 sort of primary dimensions to cultural responsive, cultural role responsiveness when it comes to therapy with ethnic minorities. So recognizing that attitudes and beliefs can negatively influence interactions with culturally different individuals, recognizing the importance of multicultural sensitivity to understanding culturally different individuals, and then ultimately applying culturally appropriate skills in the clinical domain and in other applied situations. So certainly there's some overlap in terms of what clinicians think, the things that clinicians think are important when working with minorities, and what the APA recommends. But one question is, how does one do cultural responsiveness? Here there are many, many models. So perhaps the broadest model was developed by Lloyd Rogler and sort of summarized in an article in American Psychologist about 25 years ago. At the very broadest level, just increasing access to mental health services is a way of being culturally responsive, Rogler would argue. So you can increase access in a number of ways, but language access, so providing services in the language of the client, the primary language. Geographical access, so making sure that there are clinics or services available in the places where the client lives, and that can also include doing home-based interventions. Another way to be culturally responsive, he would argue, is selecting traditional treatments that fit the cultural background of participants. So Rogler and others have argued that ethnic minority clients, for example, tend to prefer more directive interventions. So instead of providing more insight-oriented approaches, maybe when you're working with minorities, you should use more behavioral or cognitive behavioral approaches that are more focused on directly on problem solving and giving clients clear direction in terms of what they should do within treatment and outside of treatment. And then at the third level, Rogler argues for modifying traditional treatments to match the needs of the client population. In other words, this is where you get into the tweaking of the intervention and actually making changes to a standard intervention to make it more appropriate. Guillermo Bernal has a model that really focuses on using appropriate metaphors when working with the client and also making sure that the language that's used in treatment is appropriate to the client population. Sue et al. Have a tripartite multicultural competencies model. And in a review about a decade ago, Fuertes and Gretchen outlined a number of theories of multicultural counseling, but they focus primarily on 8 that have the greatest potential to be tested empirically. But there are many, many models out there in terms of how to do cultural competence and how to be culturally responsive. So are there some broad things that are recommended when working with ethnic minority populations? Well, the answer is yes. There are a number of things that tend to pop up repeatedly. Not everyone in the field agrees that these are necessarily good things, but they are very common recommendations. And I call them pan-minority recommendations here. So as I mentioned before, using short-term, time-limited, pragmatic, directive, goal-oriented, and problem-focused treatments. And the thinking is that minorities, particularly African-American and Latino, are thought to prefer these sorts of treatment rather than more insight-oriented approaches. Being attentive to the effects of minority status or discrimination. In fact, some experts argue that in your very first session, you should make some mention of the individual's minority status and ask them if they think it's relevant at all to the presenting problem. And then if it is, then you should target it in some way. Assessing whether the behavior matches the values and norms of the host culture. In other words, the behavior that you're seeing or that they were referred to may seem problematic, but perhaps in the client's culture, it's normative and not particularly problematic. Assessing and validating the client's experiences with racism is another common recommendation. Attending to nonverbal or indirect forms of communication. And then finally, role induction. And this basically refers to orienting clients to what the therapeutic enterprise is all about. What's the client's role, and what are the expectations of the client coming into therapy, and what should the client expect from the clinician? And the thinking here is that many minorities don't really understand what therapy is supposed to be about, or maybe they have stereotypes about what it's about. So one of the first things that you should definitely do with them is to orient them to what therapy is about. And then there are more specific recommendations that are thought by some to apply to specific minority groups. So for African Americans, for example, many folks recommend incorporating spirituality and faith-based coping into the therapy enterprise. Others recommend that you selectively use African American vernacular English, or Black English for short. And most folks who recommend this are careful to note that if you are not a native speaker of Black English, then you shouldn't try this because it could have the opposite effect. For Asian Americans, some of the common recommendations are to accept and tolerate low levels of expressivity, to avoid comments construed as being critical or disapproving. And then for Latinos, two common recommendations are to incorporate the family in treatment, particularly when you're working with children, and using the polite form of you or usted when you're working with adults. So that's the what and the how of culturally responsive treatments. And it's just a broad overview, and I'm not telling you everything, obviously, because it's a very large literature, and there are lots of perspectives out there. But I just wanted to give you a sense for what culturally responsive treatment is thought to be, and how you might do it. So let's now move to the why. So why is culturally responsive treatment needed? So obviously, the fate of the world is not at stake, and this is just sort of a humorous stab at it. But there are serious reasons serious reasons why CRTs might be helpful. So stigma is one major concern. So we know that ethnic minorities on average, see having a mental health problem and seeking out mental health care as being more stigmatizing than do Euro-Americans. So, of course, that leads to lower levels of help seeking and underutilization of services. If you go to the patient preference literature, you'll see that ethnic minorities tend to prefer therapists or clinicians of the same ethnic background. So African Americans, on average, tend to prefer African American clinicians. Asian Americans tend to prefer Asian Americans, and so on. We know that there are many biases in the mental health system in terms of referral, in terms of the types of services that are available and accessible. So one example is that in experimental studies where you give clinicians these vignettes that could represent someone with bipolar disorder or with schizophrenia, clinicians are more likely to diagnose African Americans as having schizophrenia, and more likely to diagnose whites as having a bipolar disorder. And that's just one of many examples that show up in the literature. There are ethnic differences in psychopathology. So, for example, we know that adolescent Latinas tend to have higher rates of depressive symptomatology than most other ethnic groups. And depending on what literature, what studies you look at, they may show more suicidality as well. So again, the thinking is that you may need to do something different with this group based on different symptom profiles. Dropout tends to vary by ethnicity, and this is particularly true when you're comparing African Americans to Euro Americans. The literature is fairly consistent there. African Americans who enter treatment on average are more likely to drop out than Euro Americans. The trend is similar for Latinos and Asian Americans, but the effects aren't as robust. You see a lot more variability across studies. And then with respect to treatment barriers, the literature generally supports the view that minorities face more practical barriers to treatment access. Again, there's some variability, so some studies don't show that minorities face more barriers, but many studies do show that barriers are higher for minorities. So lots of reasons to think that culture in the context of treatment might be critical. So with that said, let's go to our major questions. So now that we know the what's, the hows, and the whys of culturally responsive treatments, let's focus on these key questions that I summarized earlier. But first, a very brief primer on meta-analysis. So what is a meta-analysis? Well, it's basically a quantitative review of a literature, and in this case, a quantitative review of the psychotherapy outcome literature. So what we did, Antonio Polo and I and our colleagues, is to search the literature and look for all of the randomized trials that we could find that focused on ethnic minority youth. And we found those that compared some sort of active treatment to some sort of control condition. So the control could be a no treatment control, it could be a placebo control, or it could be, say, a services as usual control. So if the randomized trial had an active treatment and a control group, then it was included in our initial meta-analysis. And what we tried to pull from each of the studies was something called an effect size. An effect size is basically a number that tells you overall how effective is your treatment compared to your control condition. So if it's a large effect size, that means that your treatment is a lot more effective than your control condition, which is good, which is what you want. If it's a small effect size, then that means that there might be a difference between your treatment and your control in terms of outcomes, but maybe it's sort of negligible. So for our purposes, and in the context of meta-analysis, just keep in mind that an effect size of 0.2 or so is a small effect, and it may be statistically significant, but maybe isn't that clinically significant. On the other hand, an effect size of 0.8 is a fairly large effect size and is much more likely to be clinically significant in what we're looking for. And then an effect size of about 0.5 is good too, but it's more intermediate. So that's positive and is probably clinically significant, but not as robust as an effect size of 0.8. And for all of the effect sizes that I'm going to talk about and the results of these meta-analyses are adjusted for sample size. And that's important because some of the randomized trials have very, very large samples, and others have very, very small samples. So in a meta-analysis, you make adjustments for sample size because you want to give those larger studies more weight in the meta-analysis. And you want to give the smaller studies less weight. Okay, so that's the meta-analysis primer. So what does the research say about the effectiveness of psychotherapy with minority youth? Well, Overall, it looks like there are sort of moderate, medium treatment effects. So we found an effect size in our 2008 meta-analysis of about 0.43. And the interesting thing, or there are a number of interesting things, but one thing that's interesting is that the range was from negative 0.54 to 1.71. So you have some studies that show a negative effect of treatment, and you have others that show a very large positive effect. But overall, the effect is about 0.43, again, a medium effect. And if you look more closely, you'll see that those studies that used a no treatment or a wait list condition had the largest effect sizes. Those studies that used a treatment as usual or services as usual treatment control group had the smallest effect sizes. And then those that used the placebo condition had kind of an intermediate effect. And this sort of makes sense. So basically, the more robust your control group, the stronger your control group, the smaller your treatment effect. And the weaker your control group, the stronger your treatment effect. So if you compare treatment to doing nothing, a high effect, strong effect. If you compare an active treatment to the typical services that exist out there in the real world, the effects aren't as robust on average for ethnic minorities. So overall, we found a medium effect, and treatments were generally effective for ethnic minority youth. Again, a positive development. But the evidence is limited to Black and Latino youth. In virtually all of the studies that we found, the majority of minority participants were either Black or Latino. Over the last few years, there have been a couple studies published looking at treatment effects with Native Hawaiian or East Asian American youth, but they are few and far between. The bulk of the evidence that I'm going to be talking about today is based on research with Black and Latino youth. So we know that treatments are generally effective with ethnic minority youth. So the next question then is what therapies, what treatments are effective with ethnic minorities? So in our search for the initial meta-analysis that we did in 2008 and in subsequent work that we've done, we've stumbled upon 30 evidence-based treatments for ethnic minority youth with a diversity of mental health problems, internalizing problems, externalizing problems, and then a host of other problems. So for internalizing problems, and I'm just going to give you a sample of some of the evidence-based treatments that exist out there. You've got a number of effective interventions. So anxiety management training, several versions of cognitive behavioral therapy, CBT. For depression, you have, again, a number of different types of CBTs that seem to work at ameliorating depression in minority youth. Interpersonal psychotherapy seems to be effective as well. And then with respect to externalizing problems, we actually have the most evidence. So probably about 65%, if not more, of the studies that we found focused on primarily on kids with externalizing problems and conduct-related problems in particular. So we found two treatments that seem to be effective with ADHD. First, behavioral treatment and plus stimulant medication. Parent-child interaction therapy. And then with conduct problems, again, there are a bunch of interventions, and I just have a small sampling of the interventions here. And these four actually are the ones that seem to have the most support. So brief strategic family therapy, the coping power intervention developed by John Lockman and his colleagues, multisystemic therapy developed by Scott Hingler and his colleagues, and a parent-child interaction therapy which is increasingly being implemented in community settings, along with other types of interventions. And then there are effective interventions for a host of other problems as well. So trauma-related problems, there are several things that are available, in particular TFCBT, or trauma-focused CBT, again, an intervention that's increasingly being adopted in one form or another in community-based settings with kids. With respect to substance use problems, we've got several interventions that seem to have fairly strong empirical support. Multidimensional family therapy, structural ecosystems therapy, and this is a version of Jose Schapoznik's brief strategic family therapy. And then there are a number of other interventions that seem to work for kids with mixed behavioral and emotional problems or other types of problems, MST, child-parent relationship therapy. So the point here is that there are a large number of evidence-based treatments out there in the literature that seem to have some level of support for ethnic minority youth. And if you think about the three levels of support, well-established, which is the highest level, possibly efficacious, which is the lowest level, and then probably efficacious, which is sort of this intermediate level. There are none so far that fit into the well-established category. But there are many, many that fall into the possibly efficacious or probably efficacious categories. And if you look carefully at these evidence-based treatments, you dissect them, you look closely at the randomized trials, you go to the treatment manuals, you'll see that many of the treatments have some common elements, some things that seem to appear over and again in these interventions. And this is not a comprehensive list, and it doesn't mean that these elements appear in all of the interventions, but you do see these strategies, these elements appear repeatedly in many of the evidence-based treatments. So, are treatments efficacious with ethnic minority youth? The answer is yes. We seem to find a medium effect, which is pretty good. What treatments are efficacious with ethnic minorities? Well, there are a bunch of them. We found more than 30 that seem to show some level of support with ethnic minorities. But just because treatments seem to have some level of efficacy with minorities doesn't mean that we couldn't do better. And it doesn't mean that there aren't ethnic disparities in terms of treatment efficacy. So the next question then is, are treatment outcomes worse for minorities compared to Euro-Americans? And the culturally responsive hypothesis might suggest that minorities fare worse than Euro-American youth. So we tried to put this to the test as well. So there are several ways to look at this question. One is you can look at individual randomized trials and look for those trials that do direct comparisons of outcomes for minorities versus Euro-Americans. So within a particular trial, they look to see whether ethnicity moderates treatment effects. In other words, are there ethnic differences in the effectiveness of treatment? And if you look at individual trials, you find that there's some variability. So for the most part, the studies don't appear to show evidence of ethnic differences. But for the 13 relevant trials that we found, 5 of them did seem to show ethnicity effects. In other words, one group seemed to benefit more than the other group. But the interesting thing is that the effects did not always go in the direction that we had anticipated. So if you look at these 5 studies, you'll find that sometimes the outcomes are better for Euro-Americans, but other times the outcomes are better for minorities. So generally, if you look at individual trials, the studies show no ethnicity effects. And even when you do find effects, they don't necessarily benefit Euro-Americans more. Sometimes they do, sometimes they don't. And then even when they do benefit Euro-Americans more, the findings aren't as clear-cut as you might think. So this is one of the studies, for example, where white youth seem to benefit more from treatment. And this is a study of depression intervention, a CBT, basically, for depression. And they compared outcomes for white youth and for non-white youth. And generally, the moderator analyses seem to suggest that white youth benefited more from the intervention than minority youth, the non-white youth. But when you take a closer look, you'll see that when you look at the effects of CBT for white youth and for minority youth, the effects aren't that different. So in terms of how quickly white youth recovered from depression in the CBT condition, it's pretty similar to recovery for a non-white youth. Where you see the difference, however, is with the control group. So minority youth seem to respond better to the control group than did white youth. So because you have the disparity here, you get a treatment effect. But because you have no disparity here, there is no treatment effect. So if you look at the overarching analyses, the overarching moderator analyses, it makes it seem like white youth benefit more from CBT. But when you take a closer look, you'll see that actually with the CBT, there is no real difference. So looking at individual trials is sort of one way to see whether minority and white youth differ in terms of outcomes. Another way to do it is through meta-analysis. And a number of researchers over the past decade have tried to discern whether minorities and Euro-Americans differ in terms of treatment outcomes. So generally, the researchers find that the answer is no. There doesn't appear to be an ethnic difference in outcomes in meta-analyses. So Fabiano et al. Looked at ethnic differences in outcome for the treatment of ADHD and found no ethnic differences. Wendy Silverman and her colleagues looked to see whether there were ethnic differences in the treatment of anxiety disorders in kids, no difference. John Weiss and colleagues looked at the effects of treatments in real-world settings, comparing an active treatment to usual services, and found, again, no ethnic differences in outcomes. And Wilson and colleagues did the same thing with delinquency-oriented interventions. And again, no ethnic differences in outcomes. So if, to summarize these results, the results are somewhat mixed, but for the most part, you don't really see ethnic differences in outcomes. So folks who are receiving similar treatments don't appear to show differential outcomes as a result of ethnicity. And even when you do find differences, they don't necessarily favor white youth over minority youth. Okay, so we know that treatments are generally effective with minorities. We know that there are a large number of evidence-based treatments for minorities. And we know that overall, white youth and minority youth appear to benefit the same from identical treatments. So the next important question, then, is whether adding some sort of cultural dimension cultural infusion, cultural responsiveness, cultural adaptation, whether these things enhance outcomes for minority youth. So there's a decent amount of evidence suggesting that the answer is yes, and I have an emphatic yes here. And let me give the three primary arguments for the yes argument. First, if you look closely at the majority of the evidence-based treatments that I just quickly talked about earlier, they mostly have cultural components. Not all of them by any stretch of the imagination, but by my count, about 60% of the EBTs that have been published in the literature seem to have some sort of cultural component. Okay, so the fact that most EBTs have some sort of cultural component seems to be some evidence that culture is important or relevant. So these are just some examples of the ways that treatments have been either adapted, modified, or for culture, or infused with culture in one fashion or another. Cultural can be addressed by training therapists in one fashion or another. So Wendy Silverman and her colleagues doing an anxiety-focused CBT intervention focused on sensitizing therapists to issues regarding working with minority populations, in particular the Cuban American youth and families who were most of the minorities in their clinical trial. Melissa Rowland and her colleagues adapted MST in this way to make it more relevant to the Native Hawaiian youth who were in their trial. You can also have a match between the client and the clinician in one fashion or another. So counselor youth or peer youth ethic match is very common. Or sometimes just pairing counselors with populations where the counselors have the same sorts of cultural experiences as the client population. Another way to adapt or modify is to alter the therapy content to make it more relevant to the needs of minority youth and families. And then there's sort of a broad array of other things that are done when working with ethnic minority youth and families. Individualizing to meet the needs of minority individuals, involving cultural agents in treatment when you're trying to develop the intervention. So there are many different things that can be done and that have been done to adapt or modify for culture or infuse the intervention with some sort of cultural component. So, so the fact that most EBTs have some sort of cultural component is one piece of evidence, an indirect piece of evidence suggesting that CRTs are important. Another important piece of data is comes from the literature on ethnic match. So if you look closely at the literature, you'll see that there are a number of important studies that show that ethnic match seems to be associated with positive outcomes with minority youth and with adults. And I just have two citations here, but there are others. So ethnic match is sometimes associated with positive outcomes when you're working with minority youth and families. And then more recently, there have been a series of meta-analyses that seem to show that culturally responsive treatments seem to work better than control conditions. So this is just a summary of some of the effects from these meta-analyses. These compare culturally responsive treatments to miscellaneous control groups. And this is a study by Nguyen focused on high-risk youth, or it's a meta-analysis focused on high-risk youth. A large-scale meta-analysis by Garner and Smith that included mostly adults. Our meta-analysis, at least the part comparing the adapted treatment with the control condition, an average of 3 meta-analyses by Hodge and colleagues, and then a recent meta-analysis by Smith and colleagues, and by Benish. So if you look, you'll see that they all show that CRTs are more effective than control conditions, and in the case of Benish, more effective than what they call the bona fide therapy control, something that I can talk about later if you're interested. In every case, you have a small to moderate effect size. So the smallest being the average of the Hodge et al. Studies, and the largest being the results from the Smith et al. Meta-analysis. So again, seeming to suggest that CRTs, culturally responsive interventions are effective, and that culture is important. Well, yes, but maybe not. So if you look at other data, then it sort of challenges this yes perspective. And let me talk a little bit about that. First, importantly, even though there are individual studies showing that ethnic match seems to be associated with positive outcomes at times, if you look at the meta-analyses, and there are 2 of them so far that I've been able to find, they both show that ethnic match does not seem to be associated with better treatment outcomes, in other words, symptom reduction, and it also doesn't seem to be associated with reductions in dropout. So some individual studies show a positive effect, but when you aggregate all of the studies, put them all together, and calculate an effect size to see how robust the effects are overall across the literature, you don't get much of an effect. And then the second piece of evidence challenging the yes perspective is some data from our meta-analyses, by the meta-analyses by myself and Antonio Polo. And I'll talk about that really quickly. So there are 2, I think, good ways to look at whether cultural responsiveness enhances treatment outcomes. Method 1 is to take all of the randomized controlled trials that you can find that compare a culturally responsive treatment to a control. And then you find all of the randomized trials that compare a generic treatment to a control. And then you calculate the effect size for both, and you line them up and see whether there's a difference. That's method 1, and I'll talk about that more in a second. Method 2 is to look only for those randomized trials that do head-to-head comparisons of culturally responsive versus generic treatment. So in other words, look for those treatments that take a generic intervention and then compare it to a culturally modified version of the same intervention. And you aggregate all of those studies and see what kind of effect that you get. So we did both. And let's start with method 1, where you have these separate trials, those that focus on generic interventions and those that focus on culturally responsive interventions. And if you look at our figure, you'll see that when you use a conservative definition, then there's essentially no difference. So the effect size for the generic interventions and for the culturally responsive interventions are pretty much the same. No difference at all. And the same actually applies here. So it may look like the generic intervention is more effective than the culturally responsive intervention using the liberal definition, but this difference here isn't significant. So whether you use a conservative definition, which basically refers to finding evidence of cultural responsiveness in the randomized trial in the study, or a liberal definition, which refers to finding evidence from other sources, like from treatment manuals, from chapters, etc. You really don't find any difference between culturally responsive and generic interventions. So a second way to do it is to focus on those interventions that do head-to-head comparisons. And I think the best example of this is the recent study by Kristen McCabe and Mei Ye, comparing a culturally modified version of PCIT, or parent-child interaction therapy. So comparing a generic version of PCIT to a culturally modified version of the same intervention. And they found that there wasn't a significant difference, but when you look at the effect size, it's kind of in the small to moderate range, suggesting that the culturally modified version might be somewhat more effective than the standard version. So this is good. This is good. But when you look at the other child-focused studies that compare a culturally modified version of a treatment to a standard treatment, you get some pretty disappointing results. So the oldest study is one by Jose Shapoznik and colleagues, where they took a standard version of brief strategic family therapy and compared it to a bicultural competence model of the same intervention, and found essentially no effect. More troubling are some recent studies. Well, actually, the Grotniski study isn't that recent, but it basically took a narrative modeling therapy, took a culturally focused version and compared it to a non-culture focused version of the same intervention, and found that there were no significant effects. But if you look at the direction of the effect size, it's just not going in the right direction. This is not the way we want things to look. And the same with the recent unpublished study by Burro Sanchez and his colleagues, taking a culturally modified version of CBT for the treatment of drug-related problems in Latino youth, and comparing it to a standard version of the same. And again, the effect size is in the wrong direction, suggesting that a trend favoring the standard intervention over the culturally modified version. So these are the 4 youth interventions that I was able to find doing these head-to-head comparisons. And here, I take all of the studies that we managed to find doing head-to-head comparisons, and there were 10 of them. So there are studies that show positive effects, which is good. But then there are an equal number of studies that show negative effects. So these studies suggest that culturally responsive treatment can be effective, particularly these 3 studies. But these studies suggest that you might get iatrogenic effects. So by doing the cultural enhancement, you might be doing more harm than good, something we did not expect. And then if you aggregate across all of these studies, you get a very low effect size, 0.02, which is really negligible, basically. So another way to look at our negligible effect size is when you compare it to the other effect sizes reported by other investigators. So whereas we compared culturally responsive treatments to generic equivalents of the same interventions, these other studies compared culturally responsive treatments to miscellaneous control groups, or in the case of Banish, to what they call bona fide treatments. So, to summarize, what do we know so far? Well, encouragingly, therapies seem to be generally effective for minority youth. And we've got a bunch of treatments that have some sort of evidence base with minority youth, and for Black and Latino youth in particular. If you look at the limited literature that focuses on comparing outcomes for whites and minorities in the same clinical trials, minorities and Euro-Americans seem to benefit equally from the same intervention. And maybe the thing that surprised us most was that there was no persuasive evidence so far, despite the effects from some randomized trials, that cultural responsiveness enhances treatment effects for ethnic minorities. So this is what we know so far. What do we what do we not know? Well, lots of things we don't know. So what about treatment effects for other minority youth? Well, we've got a few trials out there that focus on Native Hawaiian youth. One trial that I know of with East Asian American youth. One trial that I just found recently focused on Native American youth with existing mental health problems. But for the most part, the evidence we have is for Black and Latino youth, and we really don't know much about whether these treatments work for other minority youth. And there are also a number of problems, serious, important problems about where we really don't have much of an evidence base when it comes to ethnic minorities. Autism, eating disorders, OCD, obsessive compulsive disorder. In fact, in the case of OCD, there was a recent study published just this year, I believe, that looked at 40 randomized trials of the treatment of OCD and found that not a single one had more than 20% minority representation, and none of them looked at outcomes specifically for minority individuals. And 4 or 5 of them focused on youth, and none of them targeted predominantly minority youth. So when you think about these problems and the evidence base for minorities, we really don't have anything. Another important question: does immigration or acculturation status affect outcomes? We really don't know. We have some suggestive evidence, and I'm going to talk about something very preliminary from some work I've done in a minute. But again, we don't really know. And then a big question, given how important theoretically culture is with respect to minorities, is this: how do we optimally make treatments culture responsive for minority youth? And I would argue we really don't know at this point. So the question is this: given the sort of theory that I outlined early on, and given the findings that I've summarized over the past hour, is the cultural responsiveness perspective valid? I think it may be, but it may look, cultural responsiveness may look different than the way that we typically envision it. And I'm sort of writing about this now, and there are actually 10 lessons that I've learned from looking at this literature, but I'm going to summarize 5 of those lessons for you now very quickly. First, effective culturally responsive treatments may not even require cultural knowledge or cultural competence, for that matter. And maybe the best example of this is a study by Donald Danzero and his colleagues in '96, where they added something called node link mapping to a standard drug counseling intervention focused primarily on ethnic minorities. And they found that this enhanced counseling, the counseling that added the node link mapping, led to greater retention among participants and less drug use for ethnic minority drug abusers. So adding this node link modeling I'm sorry, node link mapping approach enhanced treatment outcomes for minorities. And node link mapping, in short, is basically this visual communication tool or strategy that allows the counselor and the client to to basically represent the things that are happening in treatment in picture form. So things that they're talking about are kind of sort of mapped out visually for the client. And the Danzero and his colleagues basically argue that node link mapping is culturally responsive in that it focuses on reducing communication barriers between clients and counselors who don't share the same cultural knowledge, the same language skills. So the node link mapping does not explicitly incorporate racial or cultural themes, but it's sort of implicitly cultural in that it helps, at least in theory, to reduce the boundaries between the client and the clinician. So again, effective culturally responsive treatments may not require cultural knowledge or cultural competence. So point 2, successful CRTs may be redundant with what clinicians do anyway. So over the past 20 years or so, there have been a number of surveys that in one fashion or another have asked clinicians about their practices when working with ethnic minority populations. So one survey by Harper and Iwamasa, for example, asked CBT clinicians who work with adolescents, who work with minority adolescents, to what extent they do some sort of adapting or tweaking of the intervention when they're working with minorities. And they found that the overwhelming majority, about 75%, indicated that they did do some sort of adaptation. And other surveys seem to suggest something similar, that the majority of white clinicians who work with ethnic minorities do some sort of adapting or alteration of the treatment, or at least are attentive to culture. Now, sometimes they have trouble articulating exactly what it is that they do that's different, but the majority of white clinicians who are surveyed do say that they do different things when they're working with minorities. So it could be that that culturally responsive treatment, cultural competence, is something that many clinicians just sort of do intuitively. Just like if you're working with women versus men, if you're working with kids versus adults, if you're working with gay, lesbian, bisexual populations versus straight populations, many clinicians will say that they do subtle, or maybe not so subtle things differently with these populations. And maybe the same thing happens with regard to culture and culturally different individuals and ethnic minority populations more specifically. Another possibility is that cultural responsiveness may be important, but only for low acculturation individuals or immigrant individuals. And if you look at the literature, it's a mixed bag. So a meta-analysis by Greiner and Smith find that overall, acculturation status doesn't seem to matter, but for immigrant Latinos, or for Latinos more broadly, for less acculturated Latinos, you seem to get the strongest effects of these culturally responsive interventions. On the other hand, a meta-analysis by Webb focused on smoking interventions for African Americans found that culturally responsive interventions seem to be less effective for African Americans, and in particular for African Americans who had a stronger cultural identity. So really in the direction opposite of what you'd expect. And then we, in my lab, did a study a while ago focused on the treatment of phobic Asian Americans. And we took a pretty brief intervention, one session treatment for phobias, and we randomly assigned Asian Americans who were phobic to one of three conditions. Standard one session exposure treatment, culturally adapted one session exposure treatment, or self-help manual. And the culturally adapted intervention was adapted in a number of ways. So 7 major adaptations. So the biggest adaptation was that we made the adapted intervention more directive than the standard intervention. For those of you who are spider phobic, you may want to turn away from the screen for a second. Okay, so these are some examples of the spiders that we used as phobic stimuli. And to give you a sense of what we did, the first step might involve putting your finger in a tank with a spider, and then you would have the spider crawl on your arm, and then your leg, and then your head. And then we do the same thing, but with a larger spider. So we did that sequence 3 times, and each time with a larger spider. And by the end, you had to have 2 spiders crawling on you simultaneously. So that's the basic procedure. Very much an exposure-based intervention. So what did we find? Well, with the 2 active interventions, the 2 OST interventions seem to have the strongest effects. So in terms of behavioral approach, in other words, at the end of treatment and 6 months later, being able to touch the spider and hold and manipulate the spider, we got pretty robust effects. And the adapted intervention was somewhat more effective than the standard intervention, and both were way more effective than the self-help condition. But what was more interesting were some of the moderator effects. So we found that we got the best effects for low acculturation Asian Americans in the adapted condition. So if you had a stronger Asian identification and you were in the adapted condition, then you tended to have the best outcomes, basically. So this is a case where acculturation status did seem to be associated with how effective the treatment was. So that's the third lesson, that acculturation status might affect outcomes, although not always in the expected direction. Fifth, oh, I've got the numbering wrong. This is actually number 4, and this is number 5. But number 4, culturally responsive interventions can disrupt fidelity to core treatment practices. This is an interesting argument recently made by a number of scholars. And basically the argument goes something like this. Culturally responsive treatment and cultural infusion and cultural adaptation might be helpful, but if you do too much of it, it can take away from the things that we think might be effective with the standard treatment practices. So in other words, if you spend too much time doing culture, then maybe it's a zero-sum game. And it means that you're spending less time doing those active standard things that we know get us the most bang for our buck. And an interesting study that doesn't deal directly with culture, but sort of looks at this issue in a different sort of way, is one done by Schulte and colleagues in Germany, where they compared an individualized exposure intervention, or an individualized intervention to a standard intervention for phobias. And in the standard intervention, it was the basic manualized exposure-based intervention. And in the individualized, the therapists were basically told, hey, you know, this person has a phobia, and they've and you've got all of these clinical tools that you know how to use as a CBT therapist. Go out and treat them. What they found was those who got the manualized, standard, by-the-book intervention had better outcomes than those in the individualized intervention. And Schulte and colleagues did sort of scratch beneath the surface a bit to try to figure out why that was. And what they found was that in the standard manualized approach, the therapist stuck to the manual for the most part, and they did lots of exposure. And what we know with respect to phobias is that exposure is the thing that's going to get you the most bang for your buck on average. So exposure was what they did for the most part. But when you looked at the individualized condition, they did lots of different things. They did some exposure, they did some anxiety management training, they did some psychoeducation, they did some relaxation therapy, but they didn't spend as much time doing the exposure, the thing that gets you the most bang for your buck. So there's a clear parallel here, some might argue, with regard to focusing on culture in the context of treatment. At some level, focusing on culture might be important, but if you focus too much on it, it could take away from other active ingredients, other things that we know are important or critical in terms of getting good treatment effects. And that leads to our our final lesson, and that's that sometimes CRTs may do more harm than good. And again, this is related to the point that I just made. And I go back to this slide where you get some positive effects for some trials that do these head-to-head comparisons, but you can also get some negative effects. So the question here is, when is a CRT a good thing? When is infusing culture a good thing? And when is it a bad thing? And I would argue at this point we don't quite know. I'm wrapping up a meta-analysis now that may shed some light on this issue. But I haven't quite finished with it yet, so I'm not going to sort of speculate too much. But I think this is an important point. You might get good effects from infusing culture into treatment, but you may get bad effects as well. So what are the implications for clinical practice? I think there are a couple. One is that if you're interested primarily in getting more minorities into treatment and getting them to stay in treatment, then there is evidence that certain really basic things can be quite effective. So reminder letters, telephone calls, engagement sessions. A recent study, not recent actually, it's more than a decade old, by McKay and colleagues found that their engagement intervention, whether it was by phone only or by phone and in person, dramatically increased the likelihood of African American and Latino families showing up for treatment and staying in treatment for at least one session. So if you didn't do any sort of engagement by phone or in person, then only 44% showed up for at least one session. But if you did do some sort of engagement, then 86 to 89% showed up. So doing these basic engagement strategies can help in terms of getting folks in treatment and keeping them in treatment. And then if the focus and the concern is about reducing symptoms, then using CBTs or the other EBTs that I mentioned, as first-line treatments, I would argue might be the way to go, at least, again, as a starting point. And I'm not the only one to make this recommendation. Others have argued for this as well. So if you're going to do culture in the context of treatment, what are some good ways to do it? I don't have a strong evidence-based response to this yet, but I do have a couple of, there are two possible approaches I want to mention, and then I want to end with a third possibility. So one way is to do what most clinicians do anyway, and that's to individualize. Again, this is a common sense approach. If you look at survey data and if you think intuitively to what you do anyway, this is probably the norm. And the good thing about this is that it allows for, obviously, individualization and allows you to tailor your intervention to match the needs of the client. The concern, though, is that if you look at the existing data, there's no clear evidence yet that this works. And if you go back to what I was saying about the, based on the Schulte study, if you do it sort of willy-nilly, without thinking very clearly about what the cultural parts are that are critical and important, and whether it's taking you away from other critical elements of the intervention, you might wind up engaging in an inefficient intervention and distracting yourself from the core active elements of an evidence-based treatment. Another approach is to focus on the research base. So one thing that we did in our study on phobias, for example, is sort of scour the literature and look for those things that the data suggested might be effective when you're trying to modify an intervention for Asian Americans. And Kristen McCabe and Maillet did something similar. They did sort of a literature review to see what sorts of things might be important. And they also did focus groups to see what sorts of things might be effective. But this takes a lot of work. And for most of you who are out there in the real world practicing, it's not a very feasible thing. So my final thought regarding doing cultural adaptations is this. You should maybe consider doing, if you reach some sort of, if your assessment says that culture is important, you're doing your evaluation at the beginning of treatment or in the middle of treatment, and it's pretty clear to you that culture is relevant in some way. Or if you reach some sort of impasse, you find that you're not making much progress and you think culture might be relevant, then it makes sense to at least give it a shot to try to deal with particular cultural factors that you think are critical or important. As I mentioned, you want to make sure that when you do inject culture into the treatment context, it doesn't interfere with your active ingredients, the things that the study or the developers of the treatment think are critical in terms of getting good outcomes, or the things that you think are critical in terms of getting good outcomes. You want to make sure it fits with your interpersonal style or your mode. So, for example, I'm not a very religious person, so if I was to try to inject spirituality into my work with African Americans, it probably wouldn't be a very smart thing or a good fit for me, but I know many other people for whom this works really well. Make sure it's something you can reasonably do. When I'm working with African Americans, for example, I do the code switching. I do kind of go into my black English when I feel it's necessary. But if you are not African American, it's probably not something you should dive into. And then I think most important, you should approach the use and the inclusion of culture as a hypothesis that you're testing, not an assumption. Don't assume that because you're working with an ethnic minority population that culture is important. Be open to the possibility that culture is not relevant, and you might try it out and it may not work. So maybe you should focus on collecting data throughout to test and to assess whether what you are trying to do is working or not. And that is it. Thank you.
Stan, thank you very much. We do have a few different questions, and I want to urge everyone to type in if you have any additional questions at this time. Please type them into the Q&A box.
Oh, I see. I see the box now. Okay, great. So these are the questions here?
Yeah, and I can go ahead. I already put them together. So,
okay.
One of them that we have, do do the outcomes change dependently on if youth is first, second, or third generation?
Well, that is an excellent question, and we don't have good data for that yet. When I showed that slide indicating what we know and what we don't know, one of the things that we don't know is how generational status, how acculturation status, how the cultural identification level of the youth and family affects outcome. So the broader cultural responsivity model would suggest that second and first generation individuals would respond best to adapted interventions, whereas third, fourth generation folks would respond better to standard interventions. But we don't have good data at this point. So it is an important hypothesis that still needs to be tested.
Okay, great. Thank you, Stan. Our next question was, are outcomes for CRTs based upon congruent ethnic groups and therapists?
It's a hodgepodge. So I told you about the studies that I found that did direct comparison between the culturally adapted intervention and the standard version of the same intervention. I scoured the literature. I've been looking for a decade for randomized trials that do that. I found 10 so far, only 10 in the literature. And this includes published studies and unpublished studies, including dissertations, only 10. And it's really a hodgepodge of things. So for some, the primary focus is on, or maybe one or two, the primary focus is on including culturally sensitive clinicians. But for others, the adaptations are more extensive. So there's no easy answer to that. So some include culturally sensitive and ethically matched clinicians, and others don't. There's not enough data at this point to say whether that makes a difference or not. But again, if you look at the ethnic match data, and by the way, pretty much all of the ethnic match studies are correlational studies, so discerning cause and effect can be challenging. But in some individual studies show that ethnic match might help or enhance outcomes and retention and engagement. But the meta-analyses, and there have been 2 of them so far, show that ethnic match does not overall, across studies, appear to be associated with better outcomes for minorities.
Okay, great. Thank you. And so we just want to open up. We have a few more minutes for questions before I do have one more question that was asked various times, Stan, if whether or not PowerPoints would be shared with the participants here today, and if we were
I'm happy to send a version to you,
okay.
And
yeah,
and disseminate as you wish.
Okay, awesome. That's great. And okay, if we don't have any further questions or comments come into us, the Q&A box is open. So, okay. Let's see. No, I'm not seeing anything quite yet coming in. All right. Well, Stan, I know that the California Evidence-Based Clearinghouse would like to thank you very much for being our presenter here today.
Well, thank you for giving me a chance to talk about something that I'm excited to talk about.
Great. Oh, wait, we do have a quick question that came in here.
Oh, sure.
We have a couple more minutes, that's all right. Do we have any evidence on whether non-native language speakers can be effective?
Meaning clinicians, or whether existing treatments can work with individuals who are non-native speakers.
Okay, he's clarifying here. Clinicians who struggle with the other language.
Interesting question. Well, one thing that is sorely missing, is sort of good treatment outcome or treatment process literature dealing with clinician behaviors and clinician characteristics, particularly when it deals with minority populations. So the short answer is we don't know. I know that there is a very large literature suggesting that clinician factors aren't quite as important as we tend to think they are. So we know, for example, based on many reviews and a number of meta-analyses, that paraprofessionals, people without a lot of training in doing psychotherapy, seem to generally be just as effective as professionals in terms of getting good clinical outcomes. So what it means is that you can train undergrads to do some of the things that professionals do, and often get effects that are just as good, assuming that you provide adequate structure and supervision and oversight and some sort of manual to those paraprofessionals. So my guess is that individuals who maybe speak English as a second language, in terms of their technique, if you can get them to learn sort of basic, therapy skills, and you can get them to engage adequately with the client population, then you're fine, and that's probably the pivotal factor. But I can't point to any literature at this point that would back that up.
Great.
All right. Well, thank you everybody again. Thank you all the attendees. Thank you, Stan. And I will be sending all the attendees a brief survey after. So look forward to that, and everybody have a great day.
Thanks.
Thank you.
Thank you.
Thank you very much. Thank
Bye.
you, Sarah. Bye.
This call is no longer being recorded.